Good evening and welcome to the New York Symposium with Diane Sayre. I'm Diane Sayre. I am an independent LaRouche candidate for U.S. Senate now in 2024. And tonight's discussion will be dealing with the crisis in healthcare infrastructure in the United States and also give people a sense of some of what's happening internationally, because while you wouldn't know it from the mainstream U.S. media, everyone on the planet is not willing to go along with the transatlantic collapse and complete disregard of the dignity of human life. Now, I just want to first of all say that the Executive Intelligence Review is going to be holding a symposium or press conference tomorrow, which will feature people like retired Colonel, former State Senator Richard Black. It will feature Garland Nixon, Eva Bartlett, who's a very well-known Canadian-American journalist who's been spending time in the Donbass, now the independent Donetsk People's Republic, or now part of the Russian Federation, to discuss the fact that we are really on a hair trigger to nuclear war, that because the United States refuses to say in our nuclear doctrine is not no first use. Our nuclear doctrine leaves a kind of vague idea. I'm sorry, Suzanne, you need to mute. I can't mute you. Very well-known Canadian-American. Jose, can you mute Suzanne or co-host me, please? Or here we go. There we go. Okay. So at any rate, we have refused to renounce or express no first use. In fact, the U.S. seems to have a policy of preventive nuclear war, and we also haven't expressed in writing exactly what we would consider a legitimate reason to launch a nuclear war, whereas Russia has said explicitly only in case of existential threat or in response to nuclear war or response to existential threat, in effect, no first use. Now, because of the strategic situation, because the U.S. leaves this ambiguity, and because we have moved so much hardware, supposedly anti-ballistic missile systems, into Romania and Poland, but they can also be fitted with nuclear warheads, Putin said, if we don't, we may not have time for a second strike. Therefore, perhaps we need to change our nuclear doctrine to say that we may have to use a first strike. Now, he hasn't said that. He's not threatening nuclear war. The press here says, oh, Putin is threatening tactical nukes. He is not. He certainly is not going to use them in Ukraine because of the historic relationship of Ukraine and Russia. One of the reasons why the war has been so restrained up to this point is, if you know anything about the history, you'll know it's in a certain way similar to the Civil War in the United States. Everybody is related. Everybody has family members on both sides of this conflict. So that the threat is not from Russia. The threat is from the irrationality and criminal mindset. And I have to say, in my opinion, a seemingly bottomless a reserve of insanity, cruelty, sadism, I don't know what to call it, a real disregard for the consequences of one's actions. If you think about Madeleine Albright's comments that 500,000 Iraqi children dying of sanctions was a price that she was willing to pay to overthrow Saddam Hussein, well, how does she get the right to decide that 500,000 children die? So if the world is looking at that, can you wonder that they don't feel confident that they can trust when the United States might drop a nuclear bomb, especially since we're the only nation on the planet that has dropped them before? So tomorrow, there will be a press conference at 11 a.m. hosted on the Schiller Institute platform in which I'm participating, which has actually also a French general, because we now have to move to an idea of principle. This is what Helga Zepp-LaRouche is saying. You can no longer resolve conflicts based on retribution, tit for tat. It has to be like the Treaty of Westphalia, where people, in effect, draw a line and say, okay, we can't exact revenge for every crime that has ever been committed. We're going to have to move forward. We have to define certain principles based on the sovereignty of nations and the principles of non-interference in other nations and the right of every nation to economic development, and then certain human rights, healthcare being one of them. Isn't it a right of human beings to have the greatest life expectancy possible and a healthy life and a meaningful life so that you are able to make your contributions to mankind? This is, in effect, what you see in the Declaration of Independence, the right to life, liberty, and the pursuit of happiness. This is not some arbitrary thing that some dead white European males made up, as we get told. These are universal principles. If you are not alive, then you don't seem to have many other rights because you're not going to be there to enjoy them. And the whole purpose of government, as it says in our Constitution, is to promote the general welfare. If the government doesn't make your life better, then why have a government? The whole purpose of government is to make it possible for more people to live. It serves to organize society so everyone's not out like some kind of isolated infant, right? I'm going to just worry about my needs and I'm going to bump into other people and we're going to squabble over resources. No, the whole point about government is to create a kind of order where certain things can be taken for granted. And what we are seeing in the so-called Western world, the so-called civilized world, is that our governments don't seem to be very civilized. We can have Liz Truss and Tony Blinken sending text messages about blowing up the Nord Stream pipeline. And so far, Germany seems perfectly happy to be allied with people that would force them to go back to burning wood. So I won't say more. I'd like to turn it over to our guests. I will say, as always, participation in the SARE for Senate Symposium does not constitute endorsement of my candidacy. It also does not constitute agreement among any or all of the speakers on any or all of what is expressed here. The views expressed are people's own. I began this process because I think it is urgent that we have a dialogue on certain matters of life or death that are not discussed in the general public, in the mainstream press. So with that, I would like to turn it over to my colleague, Marcia Baker, who is one of the editors of Executive Intelligence Review, who is herself from a farm and agriculture background and who has a certain level of expertise on questions of physical economy in the United States and has a good picture of the healthcare crisis we are facing. So Marcia, go ahead.
Okay, thank you. And I think all of us here or watching or listening personally know or know headlines that we have a problem. I'm beginning in the United States. We know we have one internationally, but here, you know the stories. If there's a hospital you can get yourself to, can you get in the emergency room? Once you get there, is there a bed where if you need treatment, you can stay, or are you going to be sent somewhere else? Or all these kinds of questions. So this is on an emergency scale, and elsewhere in Canada, I'm talking now about just North America and Mexico and abroad, but the right response, would it not, would be for a task force to already be in operation after what we've gone through with the peak of COVID-19 and now the respiratory flu and all. There's not only not a task force, we don't even have the thinking, that's what we're up against, that would say that's the normal human common sense thing to do. So let's look at it more from the top and take the principle involved that we want to talk about And I want to just mention a short historical element here. And starting with the map that I hope you can see, this is not historical, this is present day. It just gives us an overview. The little yellow marks, the little circles, are hospitals that have shut down in just the last 10 years. 138 hospitals in 10 years. These are rural hospitals. In the 5 years before that, there were fewer than 40 shut down. And you have dozens and dozens in the rural states, Wyoming, the Dakotas, Iowa, that are on the verge of shutting down within months. So this is the scale of the problem in just simply numbers of hospitals that represents beds and treatment. We're based here in New York. I see they show 4. Probably the gentleman from upstate know more about this. You see, but you see in the South, Eastern Texas, Mississippi, Alabama, you have now whole areas without these hospitals. Now, this is rural. 138 shut in just 10 years, and you only have, I forget, maybe 1,500 or so rural hospitals. This is just a photo of a city hospital that shut in September for inpatient, Cleveland, Ohio, St. Vincent Charity Hospital, 416 beds, and it's been there since before the Civil War. One in Philadelphia with 500 beds shut this in August. So this is what's going on while all you hear are the headlines, as I just said, about, oh, it's bad here, it's bad there, but we need to move in and do something about it. Now, let me go back to the period in the middle of the last century after the Second World War in the 1940s. And I'm not saying this was a wonderful time in human history, but I will say that there was a prevalent mental outlook and moral outlook that forces had fought fascism. They had supply lines. Forces at home had built munitions and raised food. So the country was looked at and it thought, we can do something about the fact that our medical system in the United States, as of the 1940s, was inadequate for what should happen. And let me just be specific. I think there's a doctor on this panel, because many people couldn't serve in the forces in the Second World War from the United States. They had rickets or tapeworm or other problems, none of which should be. You should have a public health and hospital system. So the whole nation was looked at. This is from the mid-1940s, and this is the number of hospital beds per either per person, it's a funny way to look at it, or per 1,000 people. The light areas where you hardly had any. The dark areas where you had a lot. Don't worry about some of the Southwest desert. That's where you had very few people in one hospital, so you were relatively okay. But look at New York State. You did have some hospitals there in most areas. And so this is 3,000 counties. And the thinking was by Congress, okay, we're going to pass a survey act of all 3,000 counties, and we're going to see how many hospital beds they have per 1,000 people, and we're going to fix it by modern health standards so they have enough beds to take care of everything from childbirth to fixing your foot if you fell off your tractor or got burned in a mill. And so they passed in 1946 the Hospital Survey and Modernization Act. It's only 9 pages long, and it went through, and whether the hospital was Catholic or owned by the Shriners or the Jewish community or a county, it didn't matter. If it needed more beds, the government would lend the money and they were to be built. And that's what happened until about 1970. And the approach was, now that we see the point, I think I can get rid of this. But you see the idea. The approach was that that there would be a ratio that would serve modern care. And they figured at that time, in a city, maybe you needed 4 or fewer in New York City because you had a transportation system to get home and back and this kind of thing. Whereas in a rural area, you needed 5 or 6 per 1,000 people, excuse me. So all of this was built. And by 1970, we might have got up to 1.5 million beds each county. There were problems, by the way. Many of the hospitals beds were expanded, but they were segregated in the 40s and 50s. That was eliminated in the 1960s in the Medicare Act. So we were progressing. But then as of the 70s and 80s, and there's no use taking a lot of time now, but this all began to be taken down with the introduction of for-profit purchasing of hospitals, of health maintenance organizations, all kinds of privatization. And you got to a situation today, which is where we began. The hospitals themselves have had to be shut down. There's a lot more dynamics to this, but basically they don't have the funds to stay in operation. The government will do nothing about it. The media is not informing the citizens in order to be able to do something about it. And so we get to a situation where those trying to make a difference, I'll give an example. The rural bipartisan Congress people, Klobuchar from Minnesota, Grassley from Iowa, the Republican and Democrat, they organized something that will start January 1st. That's in 2 weeks, which is just called the Rural Emergency Hospital, REH, where it's like a storefront. You'll have an emergency room, but no beds. You'll be shipped out within 24 hours if you're able to get there. So that's the kind of non-think. I'm not criticizing that there's an attempt made to do something. And that is the kind of non-think that will get us into thousands of more beds lost. We've gone down to 700-some thousand beds in community hospitals in the country from 1.5 million in 1970. So I'll leave it there, but the principle involved, I forgot to say, is in what I just described in the 1946 Survey and Hospital Construction Act, is named after the bipartisan co-sponsors. Senator Hill from Alabama, Lister Hill, and from Ohio, Senator Burton, Harold Burton. So it's called Hill-Burton, and it also had built into it that it's the right of everyone to have access to health care. It's in the mutual benefit for everyone involved. So that's the principle that works.
Great. Thanks very much, Marcia. So just briefly, I'm going to show this short video from the president of Ghana, because having seen what we just saw, which is the number of hospital beds in the United States is now half of what it was in 1970, whereas our population is about 100 million more. It gives you an indication of what is thought of this. But for contrast, let's hear what, and just to show you where Ghana is, here it is in Africa, the western side, right there. Let's go. I think it's playing. Yes, there you can see it in the world. These are different regions in Ghana. So here we will.
As I have said before, being a Ghanaian must mean that we look out for each other. Just as the virus has disrupted our daily lives, it has also exposed the deficiencies of our healthcare system because of years of underinvestment and neglect. Whilst maternal, newborn, adolescent health and nutrition remain our top priorities, we must pay increased attention to chronic non-communicable diseases such as heart diseases, diabetes, and asthma, which have proved to be the common risk factors for the 11 deaths we have recorded from the virus. It has highlighted the need to address mental health issues in the crucial role of emergency services, to which the new fleet of ambulances and drones are responding. We must emphasize preventive and promotive aspects of health in addition to care for the sick. The virus has also revealed the unequal distribution of health facilities, as we have tended to focus our infrastructure on Accra and one or two of our other big cities. But as we've seen, epidemics and pandemics, when they emerge, can spread to any part of our country. There are 88 districts in our country without district hospitals. We have 6 new regions without regional hospitals. We do not have infectious disease control centers dotted across the country. And we do not have enough testing and isolation centers for diseases like COVID-19. We must do something urgently about this. That is why government has decided to undertake a major investment in our healthcare infrastructure, the largest in our history. We will this year begin constructing 88 hospitals in the districts without hospitals. It will mean 10 in Ashanti, 9 in Volta, 9 in Central, 8 in Eastern, 7 in Greater Accra, 7 in Upper East, 5 in Northern, 5 in Oti, 5 in Upper West, 5 in Bono, 4 in Western North, 4 in Western, 3 in Ahafo, 3 in Savannah, 2 in Bono East, and 2 in Northeast regions. Each of them will be a quality, standard design 100-bed hospital with accommodation for doctors, nurses, and other health workers. And the intention is to complete them within a year. We've also put in place plans for the construction of 6 new regional hospitals in the 6 new regions, and the rehabilitation of Efiankwanta Hospital in Sekondi, which is the regional hospital of the Western region. We're going to beef up our existing laboratories and establish new ones across every region for testing. We will establish 3 infectious disease control centers for each of the zones of our country, that is the coastal, middle belt, and northern, with the overall objective of setting up a Ghana Center for Disease Control. The recent tragic CSM outbreak, with over 40 deaths, has reaffirmed the need for ready access to such infectious disease control centers, even though in our time, nobody should die of the disease. Early reporting is what is required, and I implore everybody to heed this call. We shall make these investments in our healthcare system not because it is going to be easy, but because it is self-evidently necessary to serve the needs of 21st century Ghana. The 3 development authorities, the Zongo Development Fund, and the Metropolitan, Municipal, and District Assemblies will be tasked to place health infrastructure amongst their highest priorities in the coming years. Soon, at the appropriate time, the exact volume of investment required will be duly and transparently laid out for public scrutiny and action.
Okay. So that is very different than what we have heard from any American leaders in terms of what our nation needs. It reminds me of some of our greatest presidents, and Ghana has not, unfortunately, been able to fully deliver because of, guess what, international financial constraints and so on. But there is progress. I think 32 or so of these hospitals have begun being built. So just in contrast, I would like to now turn this over to Assemblyman John Salka, who is a member of the New York State Assembly, and who also was the Director of Cardiopulmonary Services at the Community Memorial Hospital in Hamilton, New York, for a number of years, and can share with us the situation there and what he's seen in healthcare over the years. Go ahead. Oh, and unmute yourself.
Thanks a lot, and I appreciate the opportunity to be able to share in this very, very important discussion, this dialogue that is essential now for us to be able to provide healthcare services to people in rural areas, and of course throughout the United States, and not only rural areas, but in our urban areas too. But my perspective for the past 16, well, before I retired, for 16 years was, as you mentioned, managing a cardiopulmonary department in a small rural hospital in upstate New York. We were a 40-bed hospital, and for a long time we were able to be relatively independent. It was like a big family. It was a community hospital where you knew your patients knew you, and at least in my opinion, we delivered top quality care with compassion, because we knew the people. We knew that we could handle most of what came through our doors, either acute care, emergency services, or whatever. But as you started to see more regulations, you started to see the initiation of the DRGs, the diagnosis-related groups. You started to see a lot of changes in healthcare that were primarily driven by the federal government, that was looking at the main provider, the main payer, which was Medicare, which was at that point seems like it was getting to be out of control, and the spending was going to eventually bankrupt the system. So of course the federal government, their infinite wisdom, came up with what they thought was a system. And at face value, the DRGs, and I say the DRGs because those were a major impact, at least I saw back in the 80s. And what happened, though, unfortunately, and I don't think it was any coincidence, is when the DRGs were initiated into the system fully, you started to see the quality of care. It was contrary. It was designed to increase the quality of care, but we noticed that what was happening was staff was being required or being expected to do a lot more. Like, for instance, I'll give you a small example. The average floor nurse would have 4 patients, and she would have an aide doing vitals for her, and there would be a med nurse that would hand the meds out, and the nurse did more hands-on care for the patient. And you started to see changes where now the nurse has 6 patients, 8 patients, and the aide isn't there anymore, and the med nurse isn't there anymore, and she's doing it all. And it was really an attempt by the hospitals to be able to comply with these diagnosis-related groups and be able to squeeze more out of healthcare dollars. So to me, that was a major impact, and not in a positive way in a lot of respects. It did save some money, but in my opinion, at least, and from what I saw on the front line, is it had a lot of negative impact on patient care. And of course, one of the biggest issues I had with being a director of a cardiac lab and a pulmonary service was trying to find providers for rural areas. The big payers are not in rural areas. Most of the time, the payers are Medicaid, and Medicaid reimbursement rates are embarrassingly low. So, I mean, you have a systemic issue now with providers being able to run a business, to be able to have an office, be able to practice medicine and get what they feel they should be getting out of their practice after many, many years of education and everything else that they have to deal with. And so it would literally take us years to find someone like a cardiologist or someone who, forget about anything like labor and delivery, obstetricians. We never were able to find one after we lost the one guy that we had. So, I mean, there's a plethora of problems here that I think are unique to rural medicine. Provider provision is one of them. And, we're dealing with an older population now that need more attention, need more care. And we just have a system now that's just not keeping up with it. Simply not keeping up with it. And I like we were saying earlier, sometimes years in politics makes you a little cynical too. But at this point right now, as a member of the Health Committee for the New York State Assembly, who vigorously debated single-payer health care, I look at our system of providing medical care right now as something that it's difficult to be optimistic right now. And COVID simply, don't want to say simply, but really brought out what has been a chronic issue for a long time in healthcare, which of course was the staffing, provider provision, payment. So, and I also, for 6 years, was the vice president of our county board of health. And one thing I should mention is that when COVID hit, we had all these systems in place to be able to deal with epidemics or to be able to deal with spikes in particular infectious diseases. Boards of health really do a great job. When COVID hit, the whole thing did a 180. And all the protocols, all the policies that took us years to develop to be able to control infectious disease was thrown out the window, and it was all knee-jerk reactions by politicians making medical decisions. And it really, really put a big strain that was needed the least on provision of healthcare, in particular in rural areas.
Well, thank you. I have a lot of questions, but we'll wait till the discussion period because I think people will be able to fill in parts of this. So now I would like to turn it over to Don Bliss, who's the president of the Marathon Area Volunteer Ambulance Corps. And Don, don't forget to unmute.
How's that?
Perfect.
All right. Good evening. Hi, folks. Thanks for including me. I guess our duty is to get sick people to healthcare facilities, aka hospitals. What we are based, a short history, we were a full volunteer ambulance rescue squad out of our fire station, which was started about the same time as the Hill Burton by a gentleman who was a field med in World War II. And Mr. O'Hara fired up this rescue squad and turned it into more of a rescue and healthcare ambulance service at that time. What has happened is with the jobs moving out of rural areas such as Marathon, where we are based, we are dead center between Binghamton, New York and Syracuse, New York. And we are basically an ag rural communities throughout. We run, in 2000, we had to make the move and initiate a 501c3 corporation so that we had the ability to bill insurance companies and auto insurance companies. We have Interstate 81 runs right through our town. And so we're very busy there on and off with good and bad weather. What we had to do was to hire some paramedics, and our volunteer status, we could not get calls out. We had to rely on mutual aid from other communities. And so we had to take the bull by the horns and develop this. It's been very successful. We've been doing this for 22 years now. And a lot of it is to do with the volunteer aspect of our corporation, where we have 25 members. We have 2 full paramedics full-time. We have 6 part-time paramedics, so we can offer 24/7 coverage, which we've been able to maintain. We're talking like a 225 square mile area we cover. The hospitals that we transport to are on the outskirts of our territory. Actually, our closest one is about 17 miles, which is one we use quite often. That's in Cortland, New York. And actually, if it wasn't for Guthrie, who has there are 7 hospitals or agencies that they have at this point in time. I guess they originated out of Sayre, Pennsylvania, but and they're in Corning and then upstate Pennsylvania. And that actually saved our Cortland hospital, which was faltering, to say the least. People trying very hard, but all the challenges we were getting was putting that in jeopardy. And Guthrie kind of righted the ship there, so I'd give them credit to that. What we are able to do is we have EADs and we have Alto Pulse we've put into their vehicles. We have 2 full rig ambulances and a fast response fly car, which we use to try to do some quick mutual aid from some of the outer agencies that we actually, our mutual aid is like 10 to 1. We need 1, but we give out 10 mutual aid calls. So it hats off to our crew and our staff, and the people in this community are amazing. We started our budget at 150,000 in our inception in 2000, and we've grown to 450 in our budget. And we don't even have a station. We work out of the fire station and pay a moderate rental fee. But our dreams are to go forward with a new facility, and we have purchased land, and that is on the docket if the current interest rate doesn't kill us. So therefore, what we've seen is our call volume started around 300 in the rural communities. Which I might back up. We do have 5 townships that we contract with. Our contract amounts to about 1/4 of our budget is what we charge the communities. Of course, that's based on call volume. More volume gets a higher contractual rate, just to make be it fair and parity. Our calls have grown up, and when COVID hit, we went from, like I say, the 400 to 500 calls per year to 600 immediately and grown. And then the next year after that, we went up and hit 700. And then this year we're at 710 calls. I'm going to say that, COVID was the big problem, of course. But what we've also run into is some opioid problems in rural New York State, and which has been a bit of an issue. We've been guaranteed to have a dozen opioid overdoses per year that we actually have to transport and get into. Some are called off as the Narcan affects them, then they refuse. That's another topic. I really have a hard time with Narcan being handed out like candy. So our response time, thanks to our people, is still under, and they're about 5-minute response from a tone out. So the crew's done real well. Challenges, I don't know if you want me to get into any of that or say that later on, but actually keeping volunteers and keeping fresh legs. We've got a lot of, well, I'm a senior citizen, and we've got a lot of us that toe the weight, and it's asking an awful lot of them, call after call. But that's a challenge. We're lucky. Our fire department is a great bunch of people, a great district. And they've actually got new generations of young ones who are coming into that. And we're in the process of training them for some abilities on CPR and what to do if they arrive at an accident scene before we are there, because that does at times happen, farm accidents, etc. Probably one of the challenges is like Mr. Salka said, Medicaid and the reimbursements, the payout is you can't function on that amount of money. Therefore, actually, Route 81 has been kind of nice for us. It's treacherous at times, but when you bill the auto insurance companies, they just pay. Which leads to another challenge that we are having is in New York, we can't have 2-signature insurance reimbursement checks made. So it's to the patient, and then it's up to our collection committee to see forth that we do receive those funds. And that has been a real challenge in the last 5 years. People cashing those checks. And I mean, we're a good community organization, but we do have to keep the lights on. So we do need those funds. because we need staff. Paramedics, the salary has gone up substantially in the last 2 years. Competition for those people is strong because regulations and keeping up on your ability to properly serve and legally serve, it's quite a task for the paramedics. With that, I don't know if you got any more questions.
Good. We will. I have some for sure, but I will. So let's go to our final speaker, and then we can open it up. This is Dr. Philip Lamptey, who is the President of the Associated Board of Sustainable Initiatives and Alliances for Africa. He's originally from Ghana, but now practicing in North Carolina and Ohio, and I imagine has some thoughts about all of this. And as everyone, don't forget to unmute and welcome.
Thank you very much for inviting me and being a member of this panel. I'm glad to be here. I would say that listening to my fellow colleagues speak and listening to the bold goals made by President Nana Akufo-Addo, I think back to my training in medical school and my journey to here, and one thing that rings through all the years is that the traditional healthcare model that we have is under a lot of pressure, and there are different kind of pressures that have been simmering over the past several years. If you think about in 2015, 2016, 18% of GDP goes to healthcare. And a lot of these things came to a head with the COVID pandemic. It almost seems like everything got accelerated when the pandemic hit. So problems that you had a little bit of a runway to kind of think about and find solutions to were just staring at you right within a year or a few months into the pandemic. And going through the pandemic itself has also presented a lot more challenges. As Mr. Bliss was saying, same thing we're facing on the traditional hospital model. You think about nursing. I'm sure you've heard a lot about travel nursing. You think about trying to find staffing for people who are admitted to the hospital, and that's, a big issue for hospitals as well. Backing up the emergency room and really not giving a lot of space for people to get the care that they need in a timely fashion. The pandemic itself also has caused a backlog. If you think about people who had their routine medical care put on hold for the period that the pandemic was really raging, has also kind of put people back in their healthcare needs. And for those who things that could have been prevented, like a colon cancer screening that could catch a stage 1 colon cancer, which is potentially curable, which is cheaper in terms of the financial impact on both the system and the individual. That person comes in 3 years later and it's a different picture. So a lot of pressure. It's on the traditional healthcare delivery model that we have now. But that is one thing that solutions have to be found, whether the care that we deliver, we have to start thinking about care delivery in a different way, taking advantage of advances that, we have over time, taking advantage of best evidence and commitment like the President of Ghana is making to kind of improve and increase access and brick and mortar places for healthcare. So it's basically one that will involve a lot of different opinions, different viewpoints, and coming together as a people to kind of see what the best way forward is for these kind of challenges that we're facing now. Because there is, like we said in the beginning, healthcare is one thing that everybody has to have access to, because without that, it's expensive for families, it's expensive for the system, it's expensive for the workforce, it reduces the productivity of the nation as a whole. And so it's very important that dialogue and planning to take down some of these challenging, very difficult problems to allow healthcare to move to where it is. So I'll leave it here for now, and then yield the floor back to Senate Sayers to continue.
Great, thank you so much. So Jose, if you want to put us all up, I'm just going to say a few things that are on my mind, and you can indicate if you want to speak or just start talking. I don't think we are, we have a pretty civilized panel, so I don't think we have to worry about people cutting each other off too much. One, this money question just strikes me as so outrageous. During the pandemic, these relief programs, not only were they sending stimulus checks to everyone, but the government issued literally trillions of dollars, which went to BlackRock to disperse, as opposed to actually trying to figure out what was really needed. And I know many people who needed small business loans or grants and things, that was almost impossible to get. It was really something. I was just watching a news story about a hospital closing. I'm not sure where in Ohio. It was a private company. So you have private companies taking over hospitals, saying, here's an income stream we can loot. And the best way to make a lot of money is to not give anyone care, because care is expensive. So we're going to shut down entire wings. We're going to fire nurses. We're going to do things in the name of cost, which gets me back to why actually we associates of Lyndon LaRouche so vehemently opposed Obamacare. His advisor, Ezekiel Emanuel, had this term called quality adjusted life years, where they were going to literally put a monetary value on a person based on your age primarily and certain other factors. And if you read Ezekiel Emanuel, and he's come out again now saying that we should really not be a burden on future generations. So he personally is not going to get any more cancer screenings since he's over 65. And he doesn't think anyone over 65 should get antibiotics. And he said that your life is really only worth saving if you're between the age of 15 and 45, or between 15 and 45 are your prime years. But if you're under that or over that, there's so many other factors. If you're under that, there hasn't been enough investment in you yet to make you worth saving. And if you're over that, I mean, so this financial takeover, which totally degrades what the nature of man is. I mean, you think about Johannes Kepler, who was starving in the middle of religious wars, who discovered the ordering of the planets, or Schiller, or people who had, or Beethoven, who was very ill when he was composing. By these standards, you would say, well, this person doesn't have a very good quality of life. They're suffering, and probably it's better for them to not be around that much, as opposed to recognizing that what human beings contribute is not measurable in that domain. There's a spiritual domain that human beings contribute, which you cannot touch, see, or smell, but which has an impact on everybody else. So that's one thing. Maybe we should just start with that in terms of the looting of the healthcare system. Are you seeing that? And and on that also, I want to say hospitals being incentivized, because my understanding was, and you can tell me if this is not true, that in order to get funding, you have to have a certain rate of recovery. Like if patients come back after being discharged, that is disincentivized. So public hospitals in very poor areas like DC General, which was shut down, where you're dealing with a homeless population or you're dealing with people who may not do that well, those hospitals have a very hard time getting funded, because if you look at the outcome of the patients compared to a patient in, say, a hospital in a college town with an affluent group of people who are all in their 20s, then the hospital for this, in the college town is going to get funded. The one dealing with the really sick people is not, because they're going to say they have poorer outcomes. So those are two things. So what do people have on that?
Well, if I might just chime in on that, of course, part of management in healthcare, in particular in the hospital, is attending a bazillion meetings and utilization review and infection control and all that. And one of the main topics of discussion, or the data points that we had to report on, was our readmission rate. And if it was unacceptable, and the data points and the points that were discussed regarding how often we were readmitting a patient and for what, because, for instance, if you admit a patient on day one with pneumonia, okay, and that patient has chronic lung disease, which of course puts them at a higher risk for pneumonia and certain pulmonary issues, you discharge that patient, and then the variables start. The patient doesn't comply with the medication. The patient goes home and starts smoking again, or drinking, or whatever, right? And 2 weeks later, or less, more, whatever, that patient's back in your emergency department and needs to be admitted. Well, you just ate that admission, okay? Each diagnosis had different time frames, but if in fact that patient came back, let's say for instance with COPD, if that patient came back in your emergency room within a month, you just ate that admission. So that entire stay at your hospital was now something that you were responsible for assuming the costs of. See, those are the kind of things that, so what the pressures from that are, don't admit that patient. So you're sending that patient back home sicker, and now with their comorbidities, they're coming back much sicker and much more expensive to treat. So those are the kind of things, and Mr. Bliss, I'm sure you've seen that, the frequent flyers, okay, but they're bona fide sick, okay? They have a legitimate acuity level that requires them to have a certain amount of care, and now the system penalizes a hospital for admitting that patient for something that really they should be treated for. So, and I've seen it. I've seen patients being sent home from emergency departments that you say, this patient should not be leaving this institution. And of course, they come back in a short amount of time worse. And that's, again, one of those inherent paradoxes of the systems that are set in place to try to improve the quality of care and do just the opposite. So, yeah, we were actually in particular by our chief financial officers, we were dealt with in a somewhat critical manner when we had to report on our readmissions, and particularly because I dealt with cardiac and pulmonary. A lot of patients come in with cardiac and pulmonary problems, and they would say to us point blank, what the heck are you readmitting these patients for? Well, because they're sick. Okay, well, it's a hospital, we've got to pay the bills. There must be a better way. Sometimes there is, but rarely there's not.
Wow. Others' thoughts on this?
I have one thought. No, you go ahead,
Okay.
Dr. Lamptey. Go ahead.
So I think there are several aspects to it. If you think about healthcare delivery itself in this current state, there's a lot of silos that don't really necessarily communicate with each other. So you have a patient who Mr. Bliss will go pick up because they have an acute emergency, and they come to the emergency room, they get admitted, they stay in the hospital for a few days and are discharged home. The kind of resources that they need to be able to stay at home itself is one area that is also not under the control of, not necessarily under the control of the same health system. So let's say we take the same patient who had COPD or congestive heart failure, and they don't have that much support outside the hospital. They don't have home health services to help them. And in the current state, they just go home. They are not able to even refill their medications when they get home. Somebody with those kind of problems is going to come back to the hospital. It's almost a given that they will come back. Now, the part that having some of these measures, and I think sometimes the intent and what it really, like John has already stated, the intent and what it really achieves sometimes is different because those gaps are not really closed well. So some of that has forced health systems to say, okay, so if we're sending this patient home, what kind of resources can we deploy around this patient to be able to make sure that they get what they need? Now, will all patients have the same accepted help to be able to stay at home? You have a few who are just far advanced in their disease status that whatever resources you put out there, they will still need some intensive care, so that would help them. They will still land back in the emergency room. But for those who are in the middle, a lot of them would do better if they have the resources around them compared to if they had nothing, at home to help them. Another one that sometimes you take with that is that, like some people with congestive heart failure, daily weights, calling your doctor, changing your medications helps you to know a little bit more about what you need to do with that. So I think some of these intent is there to be able to get people to be creative in terms of providing the care that people need, because the stay in the hospital itself is not it's not the best of things that we want to keep people healthy. So a lot of resources that we will put out there for people should be intended to make sure that people are staying healthy. If they have medical problems, to stay ahead of it. And then those who need to come to the hospital, they need to come to the hospital. But what do we do with them once they are ready to transition to go home? Because like I said in the beginning, we want a healthy population because that's what gives us a productive community.
Marcia, or
yeah, I just wanted to. It strikes me from the things people say, whether it's rural rescue and volunteer ambulance, whether it's giving the doctoring, whether it's running a function at the hospital. What we've been up against for decades now, we can figure it out. We could figure it out with the right mindset. As in Ghana, the proposed hospitals could be built with credit. But we've had some real stinkers from Wall Street in London, and I want to mention another name. Diane mentioned this guy, Ezekiel Emanuel, with his metric about who should live and who shouldn't. But the man, Simon Stevens, is a guy who he's British. He worked for Tony Blair, the prime minister, for 10 years. That ended in 2003. But he specialized on how in England take the National Health Service and privatize a lot of it. In other words, squeeze money out of it for United Health, for example, which is based in Minnesota. And he specialized for many years. Then in 2004, he came to Minnesota and was there till 2014, Simon Stevens, specializing in how to have Medicare and Medicaid. He went to Washington all the time and helped confer on Obamacare and set up a lot of these protocols that were discussed by John and others of what you had to do. This guy, Simon Stevens, he specialized in United Health and working with AARP, but always for more taking the money out of the hospitals, the emergency services, the home care, the assisted living. Then he went back to England and worked for the National Health Service and did more of that kind of thing. And by the way, today is the biggest strike in history of nurses and others in the National Health System of England. And tomorrow, not everybody is striking, but I mean thousands, because there's this thread of looting going on, and it always takes a name, like it did beginning in the 1970s, health maintenance organizations, or when they deregulated. John, I think you're too young, right? But in the past, you couldn't have a hospital for-profit go in and buy up other hospitals that were nonprofits. That law had to be changed. So I'm just saying, this isn't just one evil stinker from England named Simon Stevens. He's still kicking around, by the way. This was done on behalf of the kind of London Wall Street money interests that were going to make money off income, of the income stream of health care in the United States and elsewhere. And I think that now we have quite an opportunity, unfortunately, now with the world emergency such as it is, but to start to pull the curtain back on all this stuff.
If I may just make one short remark, and one of the things I observed from the years of being in medicine and then serving in the state assembly, is that I'm sitting in this chambers in Albany. It's a wonderful place to work, as a matter of fact, very historic. One day I was there and I met the Prime Minister of Taiwan. I mean, so it's because of New York City and the downstate influence, it's a very international body or room too. But I'm sitting in this body, this political body with 150 state assembly members, and there's only 4 members in that body that have any kind of experience or knowledge of medicine, be it is by payment or boots on the ground type of thing. So to try to get these people to understand, because they're the ones who pull, they hold the purse strings. They're the ones who vote on the budgets of billions of dollars that is appropriated out to Medicaid, and or at least decide on how Medicaid is spent, federal Medicaid dollars. You don't have a lot of knowledge, and I noticed that is a major problem. Is the people that are making the major decisions really don't have an idea about what they need to do to really provide services. I think we had maybe 2 or 3 people in the assembly who had any kind of experience working on a rig, okay, working with paramedics. So when you haven't been there and done that, it makes it that much harder. In all due respect, the legislature is filled full of a bunch of lawyers. I don't think there's any lawyers here, but who really don't have any concept whatsoever about how dollars should be best spent to deliver quality, compassionate healthcare. They just don't. State ed, Mr. Bliss, state ed has been a huge adversary of people in the pre-medical care field, because the testing and the requirements have gotten to be so onerous for people to be able to staff an ambulance, to be able to use the drugs and the equipment, and to have the qualifications that they need to do a good job. We put a bill forward, and I'll just say this, we put a bill forward that would have allowed nurse practitioners, nurse anesthetists, and upper level medical professionals to be able to test out and work on local ambulances. I had a nurse anesthetist who was highly qualified, and the best that he could do was drive the rig. When he would come on a trauma scene and he could intubate, he could put central lines in. I mean, he could do just about any kind of drug administration, and the only thing he could do, because he didn't have those credentials, was to drive the ambulance, and that just didn't make any sense. So we put a bill forward, and you know what? It was killed in committee.
I'm sure.
It was killed in committee. So the political landscape is not even close to conducive to what it needs to be able to channel the right resources to the right way of spending them. So that's a huge problem. They don't know what they're talking about.
Absolutely. From my observation here in a rural community that we cover, a lot of that repetitism of the patients too is some living conditions here in the rural middle of New York. There's some are quite tough, very difficult. Diabetic patients, frequent, they need to be cared for, and they're not just a frequent flyer, but they have to go back. And then I think they don't do what the doc really wants them to do, which would be, lose a little weight, watch your diet a little better. And it's just, they get in this cycle, but the living conditions are tough on a lot of them in the countryside.
When I was the vice president of the Board of Health, we did a survey, and we found that it was around 29%, less than 30% of the patients who visited their provider, who were explained to regarding their meds or their course of treatment, less than 30% actually retained that knowledge past the time that they were leaving the clinic. They just would white coat syndrome or whatever, the complexity of it. But when you have that few people understanding their treatment, and again, like you said, they don't understand. So medical literacy is a huge component, because that applies not only to their post-hospital treatment, but in the long run, you're able to. We had a program that we called the Better Breathing Program, and we taught kids with asthma how to deal with their disease. Showed them how to use their peak flow meters, when to use their inhalers, so forth and so on. We decreased hospital admissions for asthma by 45%. Now, there are real dollars and real quality of life, all right? With programs like that, New York State pulled our funding. We had to abandon the program because New York State pulled our funding. I mean, those kind of things are not only frustrating, because when they do abandon those programs, kids end up in emergency departments. And over 5,000 people a year still die of asthma. So, but we had tangible results, and because of politics, most of the funding ended up going from upstate New York to downstate, where the power base is.
Yeah.
That program was abandoned, and it was actually, it's been something that I've been trying to reinvigorate, but it's real tough to find funding, real tough.
And the power of the lobbyists.
Hospital lobbyists are very, very powerful. Very powerful. And one of my major disappointments was to see how the AMA reacted to the COVID epidemic and to the vaccine mandates. I was extremely disappointed. They caved.
Well, there certainly wasn't much interest in early treatment or preventing deaths early on. I want to take up a couple of things quickly, because we have just about 10 more minutes or a little less, which is, Don, you said that you don't support handing out Narcan like candy. I'm being a little bit of a devil's advocate. I can certainly imagine why not, but I was at a fair and learn how to, and I'm saying I'm going to learn how to stop someone. I mean, I'd be glad to save someone's life if I could, but I am not an emergency medical technician, and it probably makes people feel like there's less risk of overdosing, maybe. So so I don't know why you said that. And then I'd like to hear how you feel the economy and the collapse of the economy is affecting people, because I'm sure this hyperinflation, I mean, I saw it petitioning. We petitioned in front of grocery stores. So we met people who were coming out in tears saying, I can't buy meat, or I just paid $148 for groceries that used to cost $75 or $80. Mm-hmm. I mean, people in a total panic about their survival, and I imagine that has an impact on health. But maybe you want to start with this Narcan question.
Well, in my opinion, well, they have, there's such a thing as a Narcan party, where there will be a responsible individual with Narcan while the rest are shooting up or mething or whatever. And someone is the policeman to make sure that, well, we don't need to call 911 because we brought them back. I mean, I've had family members that got involved in that situation. I mean, that was pre-Narcan. It was just coming out, and that did save an individual, and things have come up to the better. But it's like condoning bad behavior as far as I'm concerned. I mean, if they want to put it in a vending machine so the kids can just go get it, I'm not sure that's the right way to go. I'd like to see responsible people trained, such as policemen, firemen, ambulance providers in medical field, to have that, absolutely. But if you just say, here, in case things get out of hand at your party, you can save them. Well, then with the fentanyl hitting town, I would think everybody ought to be careful about what they take and what they do, regardless of Narcan. But Narcan might open the door for more experimentation when it's handled in that regard. That's just my opinion, but I think it's a pretty good one.
Mm-hmm. Sounds well-founded.
You had another?
About the stress. I mean, because it seems there are a number of reasons why I had some guests before on another aspect of healthcare talking about the fact that people now entering the hospital are much sicker than they used to be. And I'm sure that's partly an effect of the pandemic, as was it by the doctor, I think, that people didn't get a colonoscopy. So now they're 3 years down the road with cancer that could have been easily prevented. I'm sure there's many cases like that, but I don't think it's only the lack of care during the pandemic. I think there's a lot of economic factors to this, maybe that prevent people from getting care early. So they wait, they postpone, or it's hard to get to the hospital or wherever, you don't know where to go. And then you find yourself in the emergency room with not one, but 2 or 3 interacting, complicating illnesses.
Mm-hmm. Which bogs down the system, and therefore people have to sit in the emergency room, or if they're lucky to get in a wheelchair with a broken shoulder, and wait 2 hours to hopefully they can get mended and attended to. That's a factor. But I agree that I think that economically it's a burden, because a lot of people hate the kerosene, and it's $8 a gallon. And if they've got a cold and they really got a bad one and they should be seeing someone, they just might live with it because they want to stay warm. And they want to eat. And then there's bills that come in after some of these rides. And I think some of them choose not to do it.
Right. Well, everyone will be happy to know that our Federal Reserve Chairman has said he's going to continue to raise the interest rates because somehow all of us suffering is going to help stop inflation.
Oh, that'll fix what the problem they made. Right.
John, any thoughts about this, the stress, or what are you seeing in terms of, I mean, cardiopulmonary, isn't that a big area that's affected by stress?
Yeah, I mean, over the past 10 years, we saw more 35-year-olds coming into our cardiac lab with a heart of a 60-year-old. Between the diets and the stress, it was very rare for us to send a 40-year-old to the cath lab. It became almost a daily affair. I mean, we would do probably 25 to 30 stress tests a day. And it was, like I said, rare, but it became commonplace to send, 40-year-olds to the cath lab. And because of the stress and the diet, and now with COVID and the lack of attention being given as it was before, or as it should be, you know, we have a term for it. People are medically shy now. They're afraid to go out and you know, see their doctor, or their doctor is afraid to see them. And now, of course, you know, you have a lot of doctors now because they're in short supply in the rural areas, and this is cast no negativity on nurse practitioners and physicians assistants because they do a great job filling the gaps. But you're rare now to see an actual MD, and which again, most of these things can be provided. Most of these things can be cared for by a good nurse practitioner or physician's assistant. But sometimes things do slip through the cracks more often than you can imagine. Look, I know we're getting toward the end of our discussion, which I know we could probably have for the next 20 days for that matter. Medicine's broken, okay? My 32 years of being around medicine, my opinion on it at this point is broken, okay? In a nation that was proud of their medical miracles, okay, COVID brought light to the fact that the system's been broken for a while. All right, and we've misappropriated a lot of our resources in a lot of respects to, I'll put it this way. We have raised expectations in medicine almost to an unrealistic level. People can still die of the common cold, okay? Do we make critical decisions? Do we put 86-year-olds on ventilators? Well, you better, because you got that ventilator, and families expect it now. When they come in through your emergency room, or when they are seen in your office, they expect medicine to take care of their problems. All right, and sometimes, many times, that's not possible. So we have really established by our own fault, these super sophisticated ways of keeping people alive, and morbidity and mortality is something now that people think is second place. It's second place. So, and it's a wonderful thing in a lot of respects, but also we have to start putting things in a little bit different perspective in a situation where we have very, very limited resources, And that's a real tough one. That's a cultural issue that we have created.
No, that's the thing. It is a cultural issue, and that's why Helga put it as a principle, because you only if we change the way we think about the relationship between human beings and the economy. And that was really the genius of Alexander Hamilton, recognizing that the source of wealth is not land, it's not labor, it's the mind. It's creativity. You make a discovery, and if you have a society which values the discovery, that discovery changes the way the entire society functions, and you move up to a higher level. And a nation that values that will do everything possible to protect the ability of its citizens to make that contribution. You want your children to be educated in school, not answer multiple choice exams, but actually learn how to be creative thinkers, not have classes on masturbation when they're 5 years old, but, reconstruct something that Leonardo da Vinci did, or, figure out how to measure the circumference of the earth, or do something. And you see it, I think there's a horrible kind of corruption that's crept in. And I know, John, you see this in politics, because I have to say, I have been blown away by how little people sell out for. They
institutionalized corruption.
It is astounding. But I think if you reverse it, I had some friends who have traveled to China frequently, and they described going there prior to when you had so many people who've been gotten out of poverty, maybe decades ago. And people were very closed and very nervous about, someone getting in your way, someone getting there first. They went there more recently, obviously pre-pandemic, but they went there more recently, and they said everybody was so relaxed and generous, like they were standing in the subway trying to figure out how to pay for their ticket, and someone just came up and said, look, who spoke English, I'll help you, here's what you do, and I'll buy your tickets. Or like the entire, when you're moving forward, if you're coming from backwardness and the direction is changing for the better, it's not that everything will be better, but it's the actual decision that you're not going to stay, you're not going to continue going down into the depths of despair. And I've mentioned before on the show, but I was very struck by Francis Perkins' account of Franklin Roosevelt's inaugural address, because you'd had Herbert Hoover, a chicken in every pot, people were starving, you had 25% unemployment, but the president was saying, oh no, everything's fine, denying the crisis. And when FDR came in, he said, we are in a crisis. He said it's created by the economic royalists. We've made this ourselves, therefore we can get out of it. And he gave people a sense of a mobilization to reverse it. And she said she looked out on the crowd and every single person was crying because someone admitted it's not good, it's bad, but it's our own doing and we have the power to change it.
You know, it's interesting you bring that up because, and as we talked earlier today, that people, when I'll try to explain to them what's going on, you know, sometimes they say, well, you're Mr. Sunshine. All right, I'm just trying to tell you the truth. Okay, I'm trying to tell you that there is a legislature in Albany that's spending $221 billion of your money and where they're spending it. All right, what's happening to our agricultural community? What's happening to our system of education? What's happening to medicine? Okay, it's not good. And if in fact people have to be shocked, and I don't know what it's going to take, but if people have to be shocked, does it mean a system has to crash and burn? Well, then people get hurt. All right, but what is going on underneath our noses? People need to know. They need to know. And if someone has to deliver that message and be the bad guy for delivering that message, then so be it. But what I've seen in Albany over the past 4 years, the corruption and the mismanagement and the lack of consideration for communities other than their own, it's something that people need to know. And maybe, just maybe, enough people will be told that truth, that cold hard reality. Like I said earlier, I was talking to a group from Wayne County. They represented Moms for Liberty, which is a great national organization. And I told them, you know, if you got a kid in school right now, get them out. Get them out of that school as soon as you can, because education's in a meltdown right now. And if you care for your kid to not be sexualized, to not be abused, get that kid. If you want that kid to be educated, get that kid out of school. And it's gotten that bad. It's gotten that bad. So I'm not exactly sure what's going to shock people into trying to make the necessary changes in healthcare and education and whatnot. But if we don't, we're heading in a really, really dangerous direction.
Right.
Very dangerous direction.
No, I think you're right. And unfortunately, if we're waiting for the nuclear war, we're not going to survive the shock. We'll get a terrible shock, but we won't be here to do anything about it. So, well, we're entering the Christmas season and miracles
I feel great.
have happened. So
I've got a new
like,
job. I have a new job, so and I'm excited about it. I'll be working with our new Congressman-elect Brandon Williams from the 22nd District. Don, he doesn't go down toward Marathon. It's Madison, Oneida, and Onondaga County. But I know that hospital in Cortland's a nice little hospital. That's a great hospital.
I work in Clinton, New York. So.
Oh, okay. He's in our yeah. You're in our yeah. Definitely in the district.
So I saw those political signs. Let's go, Brandon.
Yeah, that's right.
All right. Well, thank you all very much. We'll have to do this again. And if you have ideas for healthcare, please email me or Suzanne. I'm interested because
Absolutely.
I have to put together a platform, and we've also got to address things here, and more people we should be in touch with. So thank you very much. Thank you, Marcia, as always, with all the
Thank you,
details.
Marcia. Thank you.
Take care. Good
And
night.
please don't hesitate to reach out if there's anything myself or the congressman can do.